Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
Hi, I'm Swapnil. And today we are going to talk about another 3 Vivas. So, Maddie, before I start, how's life with this new COVID wave?
It's been all right. It's been pretty busy, but everyone's been working quite hard and there's good teamwork, and it's good to see the vaccination rates are still very high.
Yeah, that's the one positive or silver lining of this pandemic. I guess we managed to get 80% first vaccination rate.
Yeah.
And shout out to all the junior staff who are working really hard ICUs, and they are doing really great job.
Yeah.
So,
and you did some examining with the last couple of days. Did it go okay?
Yeah, it was exhausting, but I think overall it was pretty good experience. One of the things, a lot of shout outs to our primary prep class and how it has helped a lot of candidates. So thanks to you. So let's dive into today's podcast. Let's consider the first Viva. So you have been called to gynecology ward to review a 45-year-old female who is 48 hours post-laparotomy for large bowel obstruction. She is currently tachypneic and hypotensive. She has a background history of ovarian malignancy for which she has received chemotherapy. At surgery, she was found to have a metastatic disease and has undergone a debulking procedure and bowel resection with the formation of defunctioning ileostomy. Her current vital signs include GCS of 15, respiratory rate of 35, stats of around 90% on 8 liters oxygen via Hudson mask, few biobasal crepitations, heart rate up to 110 beats per minute, and blood pressure of 80 on 40 millimeters of mercury. On clinical examination, her abdomen is soft, distended, with pink functioning stoma. So, Maddie, can you please list your differential diagnosis for her current presentation?
So there are numerous potential causes for a presentation, with my primary differentials being either a pulmonary embolism or a hospital-acquired pneumonia. But other differentials include other infective causes, such as sepsis, such as intra-abdominal sepsis, although this is less likely with a soft abdomen and functioning stoma, or another hospital-acquired infection, such as UTI or Lyme-related infection, then resulting in multi-organ impairment. Other causes include inflammatory causes such as aspiration or ischemic bowel, which is again less likely with this functioning stoma. Cardiac causes could be ischemia causing cardiac failure or an exacerbation of a previous chemotherapy-induced cardiomyopathy in this lady. Drug-related causes are an allergic reaction, a transfusion-related lung injury, or a pneumonitis secondary to chemotherapy. Other secondary causes secondary to her existing malignancy include a lymphangitis carcinomatosis, but it's less likely in this case because it's unlikely to cause a rapid decline in hypotension unless it causes pulmonary hypertension and a cardiac decompensation, or diffuse alveolar hemorrhage. Trauma is a potential, maybe a pneumothorax or a complication from the initial surgery, such as a perforation.
So it's important to have this broad differential diagnosis and not to narrow down your diagnosis very quickly, because obviously that will give examiner enough opportunity to guide you into the next section of the Viva. So how would you evaluate the cause of this patient's deterioration?
So evaluation would involve a history, examination, and investigations. A history would include information about her presenting complaint when the fevers started, any signs of localizing infection, such as sputum production or Lyme that had been in situ for a while. Things that would think about PE or DVT, such as if she'd had calf pain, whether she'd been on DVT prophylaxis, and then information about her background, especially about her malignancy and the treatments she'd had, any previous other background history, such as existing cardiomyopathies, so the results of previous echocardiograms, any recent medications or medication changes, and any allergies. Examination would involve looking at her vital signs as already described, looking and then doing a thorough top-to-toe examination, looking for localizing signs of infection and looking at her stoma, which is active. Then investigations would include bedside tests, blood tests, and imaging. Bedside tests would likely include an ABG or a VBG to look at the gas exchange, a lactate. An ECG would be important to look for signs of ischemia or signs of PE, such as the right bundle branch block or S1Q3T3, and might consider doing a quick bedside echo at this time and a urine as part of a septic screen. Blood tests would include full blood tests, including a full blood count and UEC and LFTs, looking for evidence of any end organ impairment, a group and hold in case any surgery or further intervention is required, a full septic screen and consideration of a troponin. And imaging is likely to be important, like a chest X-ray looking for consolidation or pneumothorax or signs of heart failure, a CT-PA if there's high risk of a PE, and consideration of a CT abdomen given her recent surgery and metastatic malignancy with potential for complications.
That's correct. So again, giving a comprehensive list of investigation and specifying what you're particularly looking for when you're ordering those tests or investigation is important. Now, from here, the Viva can again go into more of how will you manage this patient? And in that kind of section, you need to probably state that what's going to be the destination of this patient, given that patient is currently on ward. So obviously transferring to ICU, establishing the monitoring, which includes routine monitoring plus invasive monitoring, and then stabilizing patient according to your A to E approach, and doing the simultaneous assessment and evaluation is important. So stating those broad principles and then outlining your investigation, routine investigation, specific investigation is the key. Now, let's say this patient comes with the diagnosis of PE, and examiner might guide you into the next section, that is, what is submassive PE?
So a submassive PE is a PE with hemodynamic stability. So it's sometimes defined as a systolic blood pressure of greater than 90. So without evidence of systemic hypotension, but with evidence of right heart dysfunction or evidence of myocardial necrosis. So evidence of right heart dysfunction can be with an ECG, which shows new, complete or incomplete right bundle branch block, ST elevation or depression, and T-wave inversion in V1 to V4 plus minus the inferior leads. Can be on echocardiogram, which can show RV dilatation and hypokinesis, interventricular septal flattening and paradoxical movement towards the LV, pulmonary hypertension or McConnell sign, which is regional RV dysfunction with free wall hypokinesis but apical sparing, or new moderate to severe tricuspid regurgitation. It can be on CTPA, which can show right ventricular dilatation, or with biomarkers such as an elevated BNP or N-terminal pro-BNP. Evidence of myocardial necrosis is with an elevated troponin. And the reason submassive PE is its own category is that these patients have a worse prognosis than those without signs of RV dysfunction.
That's correct. So let's say you stabilize this patient in your ICU, you gave some fluids, you started some vasopressor, the blood pressure has now improved, echo shows some right heart strain, but NORAD requirement is not that high. I mean, maintaining blood pressure with a minimal of NORAD infusion of 1 to 2 mils per hour. And you managed to get CTPA, which did show submassive PE. And your registrar now asks you, what is the role of systemic thrombolysis in this patient, given diagnosis of submassive PE?
Yeah, the use of thrombolysis in patients with submassive PE is controversial, and this is both in terms of the patient selection and the ideal dose. We can think about first the rationale for its use, and that this may be that it can improve hemodynamics by increasing LV filling. It might reduce the clot burden and thereby reduce pulmonary vascularization and thus the risk of chronic pulmonary hypertension, and it might prevent ongoing RV injury. The advantages of thrombolysis is that it's readily available, it's relatively cheap, it has been shown to improve systemic hemodynamics and cause quicker resolution of the clot and decrease recurrence of PE. But the disadvantages is that it has an increased risk of hemorrhage. There's no proven mortality benefit and the evidence base is not strong. Plus, there are multiple contraindications which can apply to many of our patient populations, such as prior intracranial hemorrhage, active bleeding, ischemic stroke within 3 months, any intracranial malignancy or structural disease, or recent neurosurgery or head trauma. The evidence base is small, but the two main RCTs are the PETHO trial in 2014 and the MAPIT-3 trial in 2002. The PETHO trial looked at about 1,000 patients comparing full-dose thrombolysis and anticoagulation versus placebo plus anticoagulation, and found that there was no significant difference in terms of mortality or the development of chronic pulmonary hypertension, but that there was the hemodynamic decompensation was significantly lower in the thrombolysis group, but the risk of major bleeding was significantly higher. whereas the MAPIT-3 trial compared full-dose thrombolysis and anticoagulation versus placebo and anticoagulation and found that patients with thrombolysis had reduced in-hospital death or clinical deterioration requiring escalation of treatment. And that was a composite outcome, but there was no difference in the mortality or major bleeding for these patients. And there have been also some trials that looked at the use of reduced dose thrombolysis, such as the MOPIT trial in 2013, which used half-dose TPA in patients with submassive PE and found that these patients had a lower pulmonary systolic artery pressure at 28 months, but there was no mortality difference or difference in the risk of bleeding. Other alternative to systemic thrombolysis we can think about include catheter-directed thrombolysis, anticoagulation alone, or surgical embolectomy, but this will depend on the resources available in the unit. So there's no right answer for this, but the use of thrombolysis in submassive PE needs careful patient selection and consideration.
Yeah, that's correct. And also often it involves the multidisciplinary discussions between the surgical team, intensive care, respiratory team, and IR team. And some of the centers will have this new concept of PERT team, where they come together and discuss the benefits and risks with each intervention or each approach, and then decide what's the best possible pathway. Now, examiner might want to ask, what's your approach in your unit and what will you do with this patient? And so be prepared to share how you will manage this patient if you are the in charge of this patient. And often sometimes if the patient is stabilized with minimal interventions, then often the pathway would be just to commence systemic heparin anticoagulation, aiming for APDT between 50 to 70 and monitor the patient. And then the second option will be IR guided either thrombectomy or regional or local thrombolysis. So again, it will be, as you said, considered on case by case basis. So that's the end of our first Viva. So let's move on to our second scenario. A 40-year-old previously well male is admitted to ICU for management of oliguric acute kidney injury, which is accompanied by high fever with rigors, respiratory distress, and headache. He had just returned from a brief tour of Southeast Asia. So what are your 5 likely differentials for this gentleman's presentation? And what features on history would help you distinguish between them?
So this patient likely has an infective cause for their presentation, which may be a specific overseas travel-related illness, such as malaria, leptospirosis, or dengue, or not specifically related to his travel, such as infective endocarditis or bacterial meningitis. Features on history that would help distinguish between these differentials would be epidemiological information and information surrounding his presenting complaint. So epidemiological information that would be important would be the area of Southeast Asia he travelled to, such as whether he travelled to water-prone areas, such as which would increase the risk of malaria, the time of year, such as if it was rainy season, which increases the risk of dengue, the use of prophylaxis and protective measures, and this is especially important for mosquito-borne illnesses such as malaria and dengue, whether he took chemoprophylaxis for malaria, such as doxycycline, and whether he was vaccinated, which would be important for meningococcal meningitis. Activities he performed during his trip would be important, such as freshwater swimming or exposure to live or water sports, which increases the risk of leptospirosis, or the use of IV drugs, which would increase the risk of infective endocarditis. Any unwell contacts would be important, as well as the length of stay, because this is important when you consider the different incubation periods. For example, meningitis has a shorter incubation of 2 to 10 days. Dengue is kind of in between with 3 to 14 days. And malaria has a longer incubation period of 7 to 30 days, depending on the species, as well as leptospirosis, which is also 2 to 30 days. Information about the presenting complaint is also important. So exposure to mosquito bites would be important for malaria and dengue. The pattern of illness, for example, malaria has a cyclical fever, while dengue more often has a biphasic fever. And leptospirosis is a biphasic illness, which has an acute febrile phase with influenza-like symptoms for the first week or so, followed by an improvement for a couple of days, and then an immune phase with multi-organ involvement. And other features that occur with his presenting complaint, such as for meningitis, where he might have neck stiffness, nausea, or rash, dengue, where you might have headache, myalgia, eye pain, or hemorrhagic manifestations, or leptospirosis, where he might have a conjunctival suffusion or rash.
Great. Again, it's very important to think about where this YY is heading. And given that history of return from overseas travel is important, and that's why your differential should include all those specific causes which are associated with the travel. Now, let's say this gentleman diagnosis comes back as falciparum malaria. What are the clinical features which are specific to severe falciparum malaria, and how would you diagnose it?
So clinical features would involve those on examination and those on investigation. So from on examination, severe falciparum malaria basically has multi-organ involvement, so high fevers, neurological signs such as impaired consciousness, seizures, prostration, and focal neurological deficits, evidence of shock, evidence of respiratory distress or pulmonary edema, evidence of liver involvement with jaundice, recurrent or prolonged bleeding, or oligoanuria. Signs on investigations would be on blood tests, such as with a full blood count showing severe anemia or thrombocytopenia, evidence of hemolysis, such as an elevated LDH, reticulocytes, and decreased haptoglobin, deranged LFTs, especially a raised bilirubin, evidence of DIC or coagulopathy, hypoglycemia, and metabolic acidosis or hyperlactatemia, and on UECs, acute kidney impairment. There also might be hemoglobinuria or hyperparasitemia, which is defined as greater than 2% of red blood cells parasitized, and a chest X-ray might show radiological evidence of pulmonary edema. The diagnosis is suspected, such as in this case, if there is fever and relevant epidemiological exposure, but it's confirmed by thick and thin films. The thick films estimates the parasite load and is more sensitive for detecting low-density parasitemia, whereas the thin films help to identify the species causing the malaria. Rapid diagnostic tests are increasingly important in resource-limited settings because they give results within 15 to 20 minutes. They're cheaper, less intensive, and require less training to perform. They can detect malaria parasite antigens, so can confirm infection, but they give no information about the parasite load or whether this is a new or persistent infection. So they're not useful for monitoring treatment. For Plasmodium falciparum, the example used is histidine-rich protein 2, which is a rapid antigen test.
Great. And how will you manage this patient given that patient's diagnosis is falciparum malaria?
So the management involves resuscitation, specific management, and supportive management. Resuscitation is the same as we do with any septic patient with multi-organ involvement. So this patient might need intubation depending on their level of consciousness and respiratory function. They'll need respiratory support, which might range from supplemental oxygen to NIV or invasive ventilation. They need full monitoring and hemodynamic support with adequate IV access, fluids and vasopressors to maintain an adequate MAP, usually of 65. Specifically, they might need benzodiazepines to treat seizures, and it's important to evaluate for cerebral malaria or coexisting meningitis, which can occur. This would be important, especially if they have decreased level of consciousness or focal deficits. And the way this is generally done is with fundoscopy, which might show malarial retinopathy and is pathognomic for cerebral malaria, a CT scan or an LP. And they'll definitely need admission to ICU. Specific management is using artesunate or quinine, and sometimes there's a combination is used if there's concerns about resistance. Adjuvant therapy is often used with antibacterial therapy, so ceftriaxone is most common as bacteremia is often common. Paracetamol 1 gram QID for 24 to 72 hours is used as it reduces the risk of hemolytic acute kidney injury. Exchange transfusions have been used in the past, but there are no clear consensus guidelines on when they're suitable or the practicalities involved. Previous indications have been for a very high parasite load, greater than 30%, or parasite load of greater than 10% with severe disease or failure to respond to treatment after 12 to 24 hours. And then the usual supportive care is important, but specifically it's important to monitor the BSL regularly as they're prone to hypoglycemia, especially if quinine is given as it stimulates insulin secretion. Nutrition, ideally enterally, PPI, DVT prophylaxis, which is often mechanical if they've got severe coagulopathy. It's important to monitor their fluid balance and have an IDC, and there's the same routine indications for dialysis. Treatment monitoring is important, so monitoring the parasite density, thick and thin films, generally every 12 hours and then daily to confirm adequate response. treating and monitoring for concomitant infections, and core temperature monitoring and treating fevers.
Thanks, Mani. That's a very extensive list of investigation and management. So well done. So that's the end of our second Viva. So let's move on to our third Viva for today's episode. The scenario is 24 hours after a transesophageal echo to facilitate the treatment of chronic AF. A 60-year-old female presented to emergency department with acute onset severe chest pain. Her current OBS include heart rate of 120 beats per minute, which is sinus rhythm, systolic blood pressure of 80 millimeters of mercury, and which has improved to 110 millimeters of mercury after receiving 1 liter of fluid bolus. Her current respiratory rate is around 32 beats per minute. Her SATs are 92% on 6 liter oxygen via Hudson mask. So what is your differential diagnosis and how would you evaluate her?
So I'm concerned that this patient has an esophageal perforation secondary to the toe, although there are numerous other potential differentials unrelated to the procedure, which include cardiovascular causes such as acute myocardial infarction, acute aortic dissection, pericarditis, a mural thrombus or myocardial stunning, gastrointestinal causes such as a perforated peptic ulcer, severe pancreatitis, mesenteric ischemia or cholecystitis or cholangitis, or respiratory causes such as pneumonia with sepsis, a pulmonary infarct, a PE, or a pneumothorax. In order to evaluate her, this would involve simultaneous resuscitation and then perform a targeted assessment and investigations. So resuscitation would involve going A to E, looking at her work of breathing as she's hypoxic on moderate FiO2 and tachypneic. So evaluating her airway, may need intubation if she's unable to lie flat for further investigations such as a CT. Avoiding positive pressure ventilation without intubation if there's concerns about esophageal perforation. Adequate monitoring, including SAPS monitoring, full hemodynamic monitoring, an IDC, adequate IV access, an arterial line, and consideration of a central line if time allows, with judicious fluid resuscitation and vasopressors. Small boluses of analgesia, usually opiates and paracetamol, and keeping her nil by mouth. And then evaluation would involve history examination and investigations. The history would involve looking at her presenting complaint, when her symptoms started and any other symptoms that were associated, looking at her comorbidities, allergies, fasting status, any neurological changes, and the details about the toe itself, whether there was any difficulties performing it. And an examination would involve a top-to-toe examination, looking for neurological changes, any radial delay, any auscultation findings on the chest, and whether her abdomen had any signs of peritonism or there was any signs of subcut emphysema. Investigations would be bedside blood and imaging. So bedside tests would look at ECG for signs of ischemia, blood gas to assess the metabolic parameters and gas exchange, as well as the lactate, a BSO and a UA. Blood tests would include full bloods, including a group and hold, a troponin, a septic serine, and lipase for pancreatitis. And imaging would first be a chest X-ray to assess for pneumomediastinum or pneumothorax. And likely she would need a CT chest and abdomen with contrast, but that would depend on the findings of the initial assessment. If there was a pleural effusion and there was a drain put in, we might send this pleural fluid for presence of food particles, looking also at the pH if it's less than 6 and there's a high amylase concentration, and looking at the culture of the fluid.
Thanks, Madi. Again, very comprehensive workup. Very important for all fellowship candidates to remember that even sometimes the diagnosis seems very obvious. It's very important to consider, again, broad differential diagnosis and present your comprehensive evaluation approach. So let's move on to the next part. So let's say the CT scan that you performed confirms now the diagnosis of esophageal perforation. So how will you manage this lady?
So this is an emergency situation and has a high morbidity and mortality associated with it. So management involves resuscitation, specific management and supportive care. We've covered the resuscitation and monitoring requirements earlier. Specific management would involve an urgent surgical review and consideration for source control. So there are many different specific management options. They include surgical options, which can be a primary repair, esophageal diversion, resection and reconstruction, but this is often delayed until the sepsis is resolved. It may involve drainage and decortication of the pleural effusion and mediastinal collections. There are also endoscopic options, which involve a covered esophageal stent. This is generally if there's a contained perforation with limited extraluminal soiling, or it's a small perforation. Or these are sometimes managed conservatively with antibiotics, jejunostomy for feeding, and drains for the collection. And this is all followed up by follow-up imaging to assess the treatment result, which is usually a CT, gastrograph, and swallow down the track. Supportive care would involve adequate disposition, which is generally to intensive care, sometimes via the OR, depending on the treatment plan. Nutrition, which would be to keep this patient nil by mouth, PPI, and they generally need TPN. Analgesia, which is regular paracetamol and small boluses of opiates or a PCA. Broad spectrum antibiotics, which need to cover anaerobic gram-positive and gram-negative organisms. So tazocin is usually what's used, and we sometimes consider antifungals if they're immunosuppressed or they've had a recent long hospital stay. And then it's important to update the family and also consider about the process of open disclosure if this is the complication from the toe.
Thanks, Maddie. Well done. So moving on to the next section of the podcast, which is the most important section according to you. I want to share some feedback from today. In the middle of the exam, actually, one candidate offered to tell me a joke, and I was like a bit surprised. And then later on, when I was chatting to her, she said that they really appreciate and enjoy your jokes. So I guess let's continue that tradition again here.
Oh, well, this one is from Jules. He is very proud of it. So be nice. Okay. Why does Ecmo not work well in Paris?
Oh, on the contrary, it actually works only in Paris. It's a high volume center there. Why Ecmo doesn't work in Paris? Because they got too many fashion brands there, and Ecmo is not really fashionable.
No, because they use 2 French cannulas.
Oh my goodness, this is truly, truly intelligent joke, Maddie. I must say we should replace you with Jules for this section for next time.
He was very proud.
I must say this is probably the top of the shelf joke so far. So well done, Jules. Okay, so thanks, folks. Thanks for listening. And if you really like this podcast, make sure that you share with your colleagues, any other candidates who are preparing for fellowship by us. We'll appreciate your any feedback, and we'll be back with another episode in months' time. Till then, stay safe and goodbye.
Thanks for listening. See you next time.